All right, thank you very much. I'm going to talk about MAC and more specifically about MAC brain. Um, for several years now, we have had anesthesia monitoring equipment that displays the MAC value on the screen. Or this should be the fraction of MAC that is present in the end tidal gases. So how far have we evolved with the MAC concept? We have ended up with a word salad, I would say. We have MAC unconsciousness or MAC awake. We have MAC immobility, we have MAC bar, and now we have MAC brain also. But we also have monitored anesthesia care, maintaining anesthesia first certification program. We have a Macintosh, and we have McDonald's. So there are a lot of Macs there. It's really a word salad now. So MAC really means minimal alveolar concentration. That's what, when we use, or when we are talking about inhaled anesthetics, that's what MAC means. And that MAC definition was designed or was determined by Ted Eager and Larry Seidman. And what it means is that at the steady state situation, MAC is the alveolar concentration that results in the immobility in 50% of animals or humans after a noxious stimulus in the absence of any other drug, and it only depends on age, nothing else. And therefore, we usually use an age-adjusted MAC when we take care of our patients. It is determined by doing a simple study. Each data point, each response in a study group is taken down as a 0 or a 1. 1 means there is movement, 0 means there is no movement, or the opposite. 0 means no movement, 1 means movement. And then you see that the effective concentration 50 is the medium concentration where you have as many patients who respond as they don't respond. This is just according to the definition of Eager and Seidman, but this is how it is actually calculated when you do an experiment in patients.
Is that out of presentation? Is that out of presentation, Madam Ray? Or is it here? Okay. Oh, now I think now I try it now.
There are several conceptual issues with how MAC has been defined. It's clear from the previous slide that minimal is not a good term. It should have been the median alveolar concentration. The A for alveolar is also wrong because, as we heard from Philip Payton, we absolutely cannot measure alveolar concentrations of any gas. Impossible. So it should have been called end-tidal concentration. And next, it's not a concentration. It really should have been used partial pressure, because partial pressure is going to be valid at any height, and we know that gases transfer from tissues to tissues according to partial pressure gradients, not according to concentration gradients. So just about everything is wrong with definition of MAC or with the use of the terms, except for M. Luckily, minimal starts with the same letter as median. So, if I may repeat, MAC is the effective end-tidal partial pressure at steady state that results in a 50% probability of the clinical endpoint being attained in a population, or effective concentration 50 or effective dose 50. And then we can look at different endpoints such as unconsciousness, immobility, or BAR, blockage of adrenergic response. Luckily, we have very steep end-tidal partial pressures versus response curves with a small standard deviation, which makes our life as anesthesiologists a lot easier. these are the three goals that we try to achieve when we give a general anesthetic. We want unconsciousness and or amnesia. We want autonomic nervous system control. We don't want extreme tachycardia and hypertension. And we want some degree of immobility so that the surgeons can do their work. They don't like to hit a moving target. They're not good enough for that. In terms of amnesia, it is very hard to determine whether a patient is unconscious during a procedure or not. How do we know? Well, when you ask a question to the patient, squeeze my hand, and they don't do it, have they not heard the question? Or are they so comfortable with the anesthetics that they don't bother squeezing your hand? If they forget the whole episode afterwards, maybe they were aware, but they don't remember. So determining unconsciousness is actually very hard to do clinically. So if we use these probability curves, then they can be split in three parts. We have the first one, unconsciousness, and we have a steep dose response curve. We have immobility. You need higher concentrations for that, higher partial pressures for that, than for unconsciousness. Finally, you have a third curve, the bar dose response curve. And these are the 50% probability of response versus no response in these patients. So this is a very standard graph that I'm sure everybody has seen. But 50% probability is not a practical goal. You're not interested in 50% of your patients being unconscious. So the probability that you're after depends on what the end point is of what you're trying to achieve. And I would say for unconsciousness, you would like to have 99.99% of your patients being unconscious, or at least having no recall. That is that when you achieve these concentrations or entitled partial pressures, means maybe 1 out of 10,000 patients you have failed to induce unconsciousness, which is a very, very good job, I would say. For immobility, achieving 95% immobility is also not bad. Because if we're really interested in immobility, we use muscle relaxants. And finally, for hemodynamic control, I would say that in our general population, not cardiac patients, but general population, if we have hemodynamic control in 85% of our patients, that's a very good starting point. And then we can continue to improve that number if we want to by using vasoactive drugs. These are the results of the evidence study in 2011, and he determined how much of a potent inhaled anesthetic that you need to induce amnesia. And actually the goal of the study was slightly different. He determined whether entitled partial pressure monitoring was better or worse than EEG-based monitoring. With EEG-based monitoring, he found that the incidence of intraoperative awareness was 0.24%. But when he maintained the fraction of MAC of 0.7, the incidence of intraoperative awareness was 0.07%, which by itself is actually extremely good, I would say. Now, the end-tidal monitoring could have even given better results because it was reported that Fmac of more than 0.7 was achieved only 84% of the time. So if you actually do a new clinical study where you really tightly control the end-tidal partial pressure, you could have results that are better than this 0.07%. So maintaining your end-tidal concentration at 0.7%, you will achieve your goal of unconsciousness in a very high percentage of your patients. There are two remaining issues that I have to discuss about the MAC concept, and that is the effect of opioids, and that's the effect of hysteresis. We know that if we administer opioids, the more opioid you give, the lower your end tidal partial pressure has to be in order to achieve your goal, whether that's bar, immobility, or unconsciousness. That relationship has been much tighter and better described by Cato in several studies that he did, where we looked at the probability of immobility and bar in the presence of fentanyl plasma concentrations that vary, but the most interesting data point is at 2 nanograms per ml, because that is the concentration in the blood, in the plasma, that gives you adequate post-op analgesia without overt respiratory depression. So again, that's a good starting point for providing analgesia. So if you give a dose like that, 2 nanograms per ml, you're not going to have a patient who is overly narcotized and will have a delayed wake up. And it will help you during the anesthetic to provide a higher probability of immobility. The concentration of your the end tidal partial pressure can be reduced by about 50% when you use fentanyl at that concentration, and bar requirement can be reduced by 75%. So that's what I mean when I say these curves are shifted to the left, and I cannot say that MAC is shifted to the left, or that MAC has changed, because MAC is determined in a patient who does not receive other drugs. So what I'm saying with this slide is that the end tidal concentration expressed as a fraction of MAC can be reduced in the presence of opioids. It can be reduced by 75, 50, and 50% for bar, immobility, and unconsciousness. So if you use 0.7% end tidal partial pressure of an inhaled anesthetic, in the presence of an opioid, you get, I would say, fantastic results in terms of incidence of unconsciousness. When we look at the goals for each of these endpoints, you see that the goals are 99.99 for unconsciousness, 95% for immobility, 85% for bar. You see that all of these partial pressures as a fraction of MAC are very close to each other. So with 0.7 MAC, you not only achieve a high incidence of unconsciousness, but you also achieve very acceptable incidences of immobility and bar. So 0.7 is, in my opinion, the clear goal for when you use end tidals, when you use inhaled anesthetics. All of what I said is true only when there is steady state. And the problem is we don't always have steady state. And the two situations where we don't have it is at the start of the anesthetic and at the end of the anesthetic. It's very important to use the proper terminology, alveolar partial pressure, or this should be end-expired partial pressure or fraction, inspired, and FD. All of these are different. But now we have also FCNS that's different from all of the other ones. The FCNS is not necessarily the same as the end tidal partial pressure. Although I said a couple minutes ago, that the transfer of agent is determined by partial pressure gradients, that doesn't mean that they're the same at any given time. Because during the first 15 minutes of an anesthetic, when the agent is washed in, the partial pressure in the brain will be delayed, the rise will be delayed. So there is a time delay between end tidal partial pressure and target tissue partial pressure, in this case the CNS. At the beginning of the case, your end tidal can rise rapidly to a plateau, but your CNS partial pressure is still low. And the same is true when you turn off the anesthetic. The end tidal can drop very rapidly, but the FCNS is still very high. So you can have two exactly the same end tidal partial pressures with very different CNS partial pressures. So hysteresis is sometimes difficult to understand by residents, and it's just a result of having compartment filling up, and that takes time. And how much time it takes is determined by the time constant. And I always explain that by using a cup of coffee and you pour in some milk. How long does it take before the black coffee turns white? Well, it depends on the size of the coffee cup, how much coffee you put in it, and it depends on how much of the milk you pour in. If you have a huge cup and you pour in a little bit of milk, you're going to wait a long time for the cup to have a white substance in it, and vice versa. So the time constant can be easily calculated by volume divided by flow. In units, that gives you time, which is what you expect. The higher the time constant is longer when volume is high and when flow is low. So it takes longer. Mathematically, this can be expressed by an exponential curve using tau in the formula there. So the time constant is the expression of an exponential process. It works with partial pressure gradients. It's volume divided by flow, but in the case of an inhaled anesthetic, volume has to be replaced by capacity of the organ for that product. And instead of inflow, just simple inflow in mLs per minute, you have to use agent transport. So you have to use, in case of the brain, cerebral blood flow by times blood solubility. That gives you the amount of agent that is washed in. These time constants can be calculated because we know the size of the organ, we know the solubility of vapor in the organ. Combined, that gives you the capacity. Organ perfusion, we know blood solubility, so we can calculate agent transport. And then we can calculate the time constant. Then it's very easy to calculate that. So we can determine how fast these compartments equilibrate with each other. And the time constant is about 3.5 minutes for ISO and SIVO, and it's a little bit shorter for DES, 2.6 minutes if you do the calculations. Which means that SIVO, desflurane is the faster in and out agent, which is something that we know very well. The concept, however, has some limitations. The CNS is not homogeneous tissue. We even don't know exactly where the inhaled anesthetics have their effect. And also CNS perfusion is not equally distributed. But the concept has been applied by Ross Kennedy, I think, who has had very good results with it. It is now incorporated in the flow eye by Gaetinger. And the Traeger with the Smart Pilot also has used the concept. And finally, Navigator, when it still existed, also incorporated the concept of time constants. So what are the benefits of MacBrain? It takes hysteresis into account. Now we just don't have to look at the entire partial pressure anymore to give us some idea of brain partial pressure. Now we can just look at MacBrain, and we know how well the patient is anesthetized, or I should say what the probability is of consciousness or unconsciousness. It eliminates the unnecessary use of higher end-tidal partial pressure, higher fractions of MAC, when you're not sure whether the patient is really adequately anesthetized or not. So you can be reassured and in the beginning of the case that the patient is adequately anesthetized when you can read off what a MacBrain really is. So this allows significant cost savings because you can use less agent. It allows fast emergence, and also it allows us to produce less pollution. All right, thank you very much for your attention. And please go and ask the questions.